Okay, so this is a patient who's had a scan as part of a research study, the CMR2 study. This is investigating patients with suspected coronary artery disease, and this is a standard protocol that involves stress perfusion, LV function and late gadolinium enhancement to look for evidence of previous myocardial infarction. And what we can see demonstrated here quite nicely is that when we look at this image here, we can see on the cine images now, so looking at the inferior wall of the left ventricle, we can see there is a subtle area of hypokinesia where it's just not contracting quite so well. When we look then on the stress perfusion images, this is a first pass perfusion technique where we've given a bolus of a contrast agent and then imaged through every single cardiac cycle so that we can see the passage of contrast through the myocardium. And as the contrast passes through, you'll see that first of all the left ventricular cavity lights up, and then there is an area of hypo-intensity or hypo-perfusion down here in the inferior wall during adenosine stress. And so this corresponds to what we understand as an area of inferior ischemia. So that fits very nicely with the wall motion abnormality that we've seen on the cine images. When we look at the rest perfusion study, you can see how I've frozen these images here at the time of first pass, but there is no defect that we can appreciably see here. So this seems to be purely an inducible defect rather than a fixed defect. Finally, when we look at the late gadolinium enhancement images, so these are the studies that are done to look for areas of scarring, fibrosis, vocal fibrosis on the ventricle, you can just about make out, hopefully, that there is a very subtle and thin area of infarction in the inferior wall, which is subendocardial. So this represents probably less than 25% of the transmural extent. So putting this all together, what we can see in this patient is a very small area of scar, but a lot of viable myocardium that's left in the right coronary artery territory. Corresponding wall motion abnormality, so there is evidence of LV dysfunction in this area that's supplied by the right coronary artery, and the stress perfusion images tell us that a large percentage of the myocardium is actually ischemic. So there clearly appears to be high-grade coronary artery disease affecting the right coronary artery, with probably at least 5 to 6 segments of the left ventricular myocardium being ischemic. So that's probably representing in the order of 25–30% of the LV being ischemic and dysfunctional, but with very little evidence of scar, so that the myocardium is still viable and would benefit potentially from revascularization. For perfusion imaging, I think 3 Tesla has significant advantages over 1.5 Tesla field strength because of the additional signal to noise that we get from the higher field strength scanner that we can invest either in terms of improving the spatial resolution or the coverage. And typically we go for spatial resolution in clinical type studies because what we know is that if we drive the spatial resolution down to maybe 1–1.5 millimeters in plane, then the artifacts on the images are much less prominent, and so it's much easier for the clinician to be able to differentiate a true perfusion defect from an artifact that's created by the pulse sequence, for example. And so you can see here, these are images that are done with very high spatial resolution. These are probably about 1.1 millimeter in plane. And any dark rim artifact that you see on the images tends to be very, very thin and quite transient. And so you can see a little bit of dark rim artifact here, for example, in the septum, but that's easily distinguishable from this very large area of transmural ischemia in the inferior wall. And it's just much easier to be able to differentiate that at 3 Tesla compared to 1.5 Tesla. I think the dark rim artifact would be larger, and perhaps the perfusion defect just might be not quite so crisply delineated. I think that's the real advantages of 3 Tesla in this setting.
And what do you feel about doing stress and rest as part of your protocol? Is it something that you normally do or not?
Again, it will vary a little bit between whether we're doing these scans clinically or whether we're doing them from a research perspective. So often from a research perspective, we're really interested in quantitating myocardial blood flow, and we can look at myocardial perfusion reserve, etc. And this does need us to have the rest study performed so that we can compare rest to stress. If we're doing clinical studies, then often we might miss out the rest scan because really the rest scan doesn't help us to delineate where fixed defects are. We get all of that information, if you like, from the late gadolinium enhancement images. So we're really only interested in inducible ischemia on clinical studies. And so we can actually speed up the workflow of the department quite dramatically if we just do a stress perfusion volumes and late GAD study rather than having to wait 15 minutes and then somewhere build in a rest perfusion study as well. What it also enables you to do is if this first stress study doesn't work very well, so if there are technical reasons why it hasn't acquired the data in the manner that we'd like, or the image quality isn't as ideal as we'd like, then what we're able to do is repeat the stress study during the same time that the patient's on the scanner. So what we tend to do is stress rather than stress rest. And that way you get a second bite at the cherry for making good quality images that you can get the diagnosis correct from. So the real benefits from a clinical perspective are not that strong, unless of course you're quite new to perhaps perfusion imaging and you're not confident of being able to differentiate true perfusion defects from artifacts, then it can help you in that early sort of phase when you're getting used to doing perfusion imaging. But if you look at most perfusion centres in the UK that are doing very high volumes, have got a lot of experience, quite often they're dropping out the rest perfusion scan now just to increase the workflow through the department because they've got that level of experience and confidence in image interpretation. Okay, so some of the factors that we look at to try and help distinguish artifacts from true perfusion defects I can explain to you. So this is a stress perfusion study, and what we're able to do is scroll through each cardiac phase point by point, and if I take you to the point where the contrast is just arriving in the left heart, so you can see here at the moment there's high signal intensity in the right ventricle, so the contrast is passing through the right heart, and now it's just coming back to the left heart. It's sitting in the LV cavity, but it hasn't got into the myocardium yet, so the myocardium is still represented by a sort of darker sort of grey homogeneous appearance, and anything that you see at this stage on the ventricle in terms of areas of hypointensity can't be due to a true perfusion defect because the contrast hasn't actually physically got into the myocardium. So we can already see that there is this dark area down the interventricular septum, which is quite thin, and because we know the spatial resolution of the scan and we know that these complex artifacts, these dark rim artifacts, tend to be only about 1 pixel in diameter, we're expecting it to be very thin. This is a typical position where it occurs, and we can see it, so it's there before the contrast has arrived. Now as we go through, and I'm just moving on each heartbeat now as I click the cursor, we can see that that dark rim artifact is still there, but as we go into the true stress part of the study, the contrast has arrived fully into the myocardium, and here the signal intensity has increased now quite dramatically, and it's gone from a dark shade of grey to a light shade of grey, and here in the inferior wall it's stayed very dark or very hypo-intense. And here it's now occupying almost the entire transmural extent of the myocardium. So this is very uncharacteristic for an artifact. This is quite clearly a perfusion defect. And we've still got the artifact on the image, but it's quite easy to see the difference between those two appearances, I think. The other thing that is also helpful as well is that you can see with perfusion defects, it's propagated through all three slices, so you can see there's an area of hypoperfusion on the basal slice, the midventricular slice, the apical slice. So again, it's corresponding to the territory supplied by the right coronary artery. It's forming an anatomical distribution of what we are expecting to see from a coronary artery lesion. Sometimes these rim artifacts, these dark rim artifacts, they cross over different coronary artery territories. So again, that leads you to suspect that perhaps it's an artifact rather than a true finding. There are all sorts of other complex artifacts that we can sometimes see on perfusion imaging, depending on the acceleration technique. This is a KT reconstruction, so there are often some breathing artifacts and reconstruction artifacts. But again, with experience and time, you get to be able to sort of differentiate really what are true pathological appearances from the artifacts across the image.